once that was done and with adequate staining, again started off with the rexis and completed the rexis. The rexis usually is the aspect that has to be taken up with a lot of patience. And after that is done, putting in the capsular tension, the hooks, the capsular hooks, which go right up to the equator, then supporting the whole nucleus with the Sioni. Now, when to put the Sioni is that million-dollar question. I think it's important to put the Sioni when it is required. The later you put it, the better it is, because you will not be entrapping the cortical matter. But you have to put it to stabilize the lens. If you feel that the stability of the lens is compromised and your next step is going to become very difficult, it's best to put in at that point of time. You can see that it's really a very hard, it's a really grade 4, grade 5 cataract. And going on with a multi-planar, gradual straight chop. And you can see the chopping gradually coming from the periphery to the center. And you can see that it's just because of the Sioni that so much of thrust is being able to be transmitted all around without the shift of the whole capsular bag. So the points to be taken home is a very patient dealing, a lot of high molecular weight viscoelastic, gradual taking up very good parameters, maintaining it as much as possible, and of course the capsular hooks which do a great job. After this is done, then putting in the bag single piece intraocular lens, and with a single piece intraocular lens, if the bag is stable enough, then you don't need to put in a segment. But here we did feel that there was an instability, and then we did put in a segment. The dissection of this lateral flap best be done initially, of course, unless you're not intending to put it in. Now, what you can see is this is actually not a segment. The segment actually dropped to the floor. So what we had again is the Sioni ring with the ident. So we broke that and then put it as a segment, which is fraught with a lot of danger, because that broken part can actually rip the capsule, and if you're not very sound, and the capsule with all the patients that you have, it just goes to waste. So we got through in this case, but it's important to have a good supply of these segments. The next case that I'm going to share with you is this young man had a trauma of a very high degree. There was total collapse of the iris, there was dialysis, the whole of the iris has come out. We even suspected an intraocular foreign body, which was of course disproved as an artifact in a later ultrasound. So we took this patient up for surgery after clearance, after the ideal segment and the posterior segment had settled down. That was really about 3 months later. After doing a primary repair in nearly one whole quadrant, you can see the primary sutures there. And you can see a knuckle of the iris tissue as well. So what we plan to do is in the back placement, but I was not sure whether there would be a clear show. So we went on, we did a very gentle hydro dissection after doing a capsular rexis and tried to rotate. Now at this point of time, I felt that the whole bag is giving way, so I put in the Sioni ring. So after putting in the Sioni ring, there was good stability, and this was a 48-year-old gentleman, I think maybe 50-year-old gentleman. So we went on to do a good nucleus management, and I was very fortunate and lucky with patients. The nucleus could be managed, but what was the problem in this particular patient is the patient did not have size has to be good, and you have to put it through a lot of patience, but high molecular weight viscoelastic, injecting and re-injecting, and then placing these two rings. So in that capsular bag, which was traumatized with a luxation, there was the Sioni, the intraocular lens, and then these two rings. So the capsular bag is such a wonderful mechanism that God has created, and with all the zonules, so even if there is a zonular rupture, which was so evident in this patient, you can see that with proper placement and proper management, these patients do extremely well. So he regains a very good vision of 6, 9 and 6, and for this patient, very fortunately, he didn't have much hair. Again, the rings do not extend right up to the pupillary aperture of 4 millimeters. So, but by and large, because the anterior capsule opacifies, that's why the glare is not much there. The last short clip is one of a patient who had an intraocular lens in his eye, and after the trauma, this intraocular lens shifted. It was a 3-piece lens. So what we thought is we could either take it out and do a vitrectomy and then reimplant well fixated. But here what we thought is, since about 120 degrees of the zonules were still intact, we wanted to thread the intraocular lens, the haptic of the intraocular lens, and so we threaded it and very gently can go in. It has to be maneuvered again using high molecular weight viscoelastic and threading it first under the haptic, going out. But before threading, one definitely needs to remember that the curvature of this needle or this protein suture has to be correct. So if it is slightly curved, and that also in the anterior part, it threads in quite well. And then going out by the railroad method through the corneal side. And once that part is threaded, you have to be very watchful, because all this time the zonules are again at risk. So at any point of time, if there is a mismaneuver, then the rest of the zonules can actually give way. So after doing the threading, the other practical tip that there is, that once the needle comes out from the corneal side, you have to put it back to the same corneal aspect. Now, at times what can happen is the needle can actually take a little bite of the corneal tissue, and then you have the cornea also intact, and that is a very severe situation after a very well done surgery. So you have to be very sure that you are actually manipulating in that plane which you have incised, and it should go into that right plane and then thread it again back again. And of course this time it is over the haptic. So once it comes out, then again, as Ajay or other presenters told it very well, that the tautness is important, not too tight, not too loose, so that it is maintained right in the proper position. Thank you very much for your patience, and I thank Ajay and the other co-instructors